Thank you. Good morning. Good morning, everyone. I would like to welcome you to today's lecture. Today we are going to talk about pharyngitis, adenotonsillitis, and laryngitis. Pharyngitis, that's the disease that affects the pharynx. Adenotonsillitis, that's the disease that affects the adenoid tonsils. And previously we saw that the adenoids and tonsils were part of the Walde's ring. And laryngitis is inflammation of your voice box. So we are going to start with adenotonsillitis. Then we'll talk about pharyngitis and laryngitis at the end. One out of 30. Common diseases that affect the tonsils and adenoids, we have acute adenoiditis, stroke tonsillitis, recurrent stroke chronic adenoiditis, and all tonsillitis, obstructive hyperplasia, and malignancy. So acute adenotonsillitis and sometimes can occur only as an acute adenoiditis, especially in children below the age of 1 year, or it can occur as a combination of adenotonsillitis. So we have adenoids and tonsils getting sick at the same time, or we can have purely tonsillitis, acute tonsillitis. Recurrent occurs when you have multiple episodes with periods of complete recovery, and maybe the episodes can amount to 5 episodes per year. So those are recurrent episodes. They keep on occurring, but between each episode, the patient is cured or is asymptomatic. Chronic tonsillitis or chronic adenotonsillitis, that's why we have infections that occur and they continue without resolution for at least a period of 3 months. That is chronic adenotonsillitis. Obstructive hyperplasia is where we have the adenoids becoming big together with the tonsils, and they cause blockage in the upper airway. So the child is unable to breathe through the nose because the adenoid tissue, which we noted last week, that is involved in the nasopharynx has obliterated or obstructed the choana, and so the patient has to recruit the mouth for breathing, and these patients most of the time come in with snoring and mouth breathing. That is obstructive hyperplasia. Then we have malignancy. Malignancies, we have what we call those that are purely from the tonsils, like lymphoma, non-Hodgkin's lymphoma affecting the tonsils, all squamous cell carcinoma novally from the oropharynx. And we can also have those tumors that can extend to the tonsils, like squamous cell carcinoma from the soft palate can extend to the tonsils, or we can have tumor in the fossa of Rosenmuller, which we saw in the nasopharynx, extending into the nasopharynx and involving the adenoid tissue. So that is it. So we shall start with tonsillitis. As you see, these are images. that are taken from oropharyngoscopic view. The patient's tongue is here beneath, and then this is the soft palate, this is the uvula. As you can see here, we have hyperemic. Hyperemic means red mucosa, which is congested, that is edema. And you see that these tonsils, which are between these two pillars, the tonsils are enlarged and they have exudates. So this patient has acute tonsillitis, and it's usually attributed to group A beta hemolytic strep. We have this other image. We also have, you see, we have grade 4 tonsillar hypertrophy with exudates and severe edema, but we can notice that we also have exudates on the soft palate, and these exudates are hard to scrap off. This is a sign of infectious mononucleosis. So we shall start with adenoiditis. Adenoiditis is inflammation of the nasopharyngeal tonsils. It can be acute, recurrent, or chronic. Acute is usually a short period below the period of 4 weeks. And we have prurient rhinorrhea, that is a pus-like nasal discharge, fever, nasal obstruction, snoring, and mouth breathing. Recurrent tonsillitis, acute adenoiditis is chronic adenoiditis. This is the type of adenoiditis that occurs for more than 3 months. And we have persistent nasal discharge. Fita, that is a foul smell. Children who you can go close and you feel that foul smelling breath. Post-nasal drip, they keep on coughing in the night because of the mucus that beats at the posterior pharyngeal wall, and nasal congestion. Most differentiated is with chronic rhinosinusitis, because we have the similar symptoms, and it's often associated with otitis media with effusion because of the how close the adenoids are to the eustachian tube, which is in the opening, which is in the lateral wall of the nasopharynx. So when they're enlarged or when they're sick, we can have infection going to the inner ear, and I mean infection ascending to the middle ear via the eustachian tube and causing otitis media, acute otitis media, or infection blocking all the adenoids, blocking the eustachian tube, causing otitis media with effusion. So when you have symptoms that extend to the middle ear, either acute otitis media or otitis media with an effusion, they are more indicative of adenoiditis versus chronic rhinosinusitis. So other symptoms usually of when we have very big obstructive adenotonsillar hyperplasia without infection, we have a triad of symptoms. We have chronic nasal obstruction, which is evidenced by snoring and mouth breathing, rhinorrhea, and hyponasal voice. So the patient speaks like that nose is blocked. Other symptoms associated with OSA include apneic spells, sorry about that. So we have other apneic symptoms, which include apneic episodes with gasping or choking. So the child sleeps while snoring, and then because they are recruiting the mouth to breathe, they end up having obstruction and they get tired and they forget to breathe, so that they have episodes of complete cessation of breathing, that is apnea. And then they have to wake up in the night gasping or choking for air. So a mother will tell you, my child's, it's like he's cutting timber, or it's a mortar that is turned on, and at the end in the night, the child stops breathing and they wake up. So that waking up is gasping for air. They have daytime hypersomnolence. So because they don't sleep at night very well, they end up sleeping also during the day. That is daytime hypersomnolence. And they have nocturnal enuresis, that is urinating on the bed. Behavior disturbance, a child who doesn't sleep, they usually affect their mental status on developing the brain. So they have violent behavioral tendencies and poor performance in school. And also, because of this chronic obstruction with episodes of apnea, they might end up having heart failure and failure to thrive. So this is a classical picture of a patient with adenoid facies. You can see they have a flat nasal bridge. As you can see, they have dark circles under the eyes because they do not sleep well, and their mouth is open because they are recruiting the mouth to breathe. With tonsillitis, we have acute, recurrent, and chronic tonsillitis. With acute tonsillitis, it's what we usually know. The patient comes in with a sore throat or dinophagia. Dinophagia is painful swallowing. And later on, they can get pseudodysphagia. They fail to swallow and they start drooling because the tonsils are grateful, they're obstructing where food should literally pass, and the patient is also feeling pain. So that's why they get dysphagia, but it is pseudodysphagia. It's not truly from an anatomical obstruction. Then they will have fever and tender cervical lymph nodes. We have seen that infection drains from the oropharynx and it goes to level 2 to the jugulo-digastric lymph nodes. So the patients will have tender cervical lymph nodes. And when you do oropharyngoscopy, you'll see erythematous tonsils, which will be with exudates. That is the first discharge. Recurrent acute tonsillitis, we have 7 episodes, usually of the similar presentation as above, but 7 episodes in a year, all 5 episodes in 2 years, all 3 episodes in consecutive 3 years. Chronic tonsillitis, this is persistent. Symptoms can proceed up to 3 months. We have chronic sore throat, tonsillolith are also known as tonsil stones. They are yellowish, hard particulates that come from the tonsils when someone tries to increase their pharyngeal pressures, like they will get a small, foul-smelling tonsillolith. They also have halitosis, peritonsillar erythema, and persistent tender cervical adenopathy. So if you have colleagues that have halitosis, a full breath, kindly do oropharyngoscopy and confirm if either they have tonsils or it could be maybe from the stomach. Epstein-Barr virus may usually appear as acute tonsillitis, and it has it is associated with splenomegaly, and it's important to do monospot testing, which is done in our labs. Lancet does monospot testing, and it is very crucial for you to be sure that it's Epstein-Barr virus, because you should not prescribe any penicillin-based regimen to this child with EBV. So this is a clinical evaluation table of what we have just discussed. You can see we have adenoids, could be obstructive or infection. Of symptoms, we've seen obstructive mouth breathing, hyponasal voice, snoring, and signs. You see the patient has a hyponasal voice, the nasal obstruction. And on investigation, as we shall see below, okay, but on investigation for chronic obstructive hyperplasia for adenoids, we do what we call a lateral neck X-ray. And when you do a lateral neck X-ray, you see that the air column in the nasopharynx has been narrowed. There's a thick soft tissue density in the nasopharynx. Also, we can do nasopharyngoscopy. Here we use a scope, an ENT scope, and we look behind the nose into the nasopharynx, and we see the adenoids. The differentials, we can have a deviated nasoseptum or rhinitis, which could be allergic. Infection, that is acute or chronic adenoiditis. We have a nasal discharge, cough, halitosis, post-nasal drip, and signs include a running nose, rhinorrhea. The nose exam, anterior rhinoscopy is normal, and the patient might have otitis media. Apart from the hematological blood workup like CBC and ESR, RCT, the routine we do for infection. We can also do sleep evaluation in case these patients we suspect they have apneic spells, and you can also do CT scan of the sinuses because you want to rule out sinusitis and also gastroesophageal reflux disease in children. It can give you post-nasal drip and a constant cough at night. So children also have what we call ulcers or ulcer disease or ulcer-like symptoms. Tonsils, we have obstructive, infectious, and recurrent. Symptoms with obstructive, we have snoring, muffled voice, and dysphagia. Infection, it can be acute or chronic. We have sore throat, halitosis, muffled voice, and tender neck lymph nodes. Sore throat, halitosis. So the symptoms usually clear-cut, the infections acute and chronic. And on examination, we can have enlarged lymph nodes and enlarged tonsils, grade 3 to 4, as we shall see. And this is done on oropharyngoscopy, which we saw, that is examination of the oral cavity and the oropharynx. Then we can have exudates and erythema if it's acute tonsillitis with tender adenopathy. And we have normal tonsils with peritonsillar erythema, tonsillolysis, decreased number of crypts, and tender cervical adenopathy. This is on chronic or recurrent tonsillitis. Investigations, we can do throat culture. That's how you take a throat swab and do culture and sensitivity. We can do the assault titers because most of the time we want to rule out group A beta hemolytic strep. We can do CBC. We can do throat culture. We can do lateral neck X-ray for obstructive hyperplasia because sometimes it's adenotonsillar hypertrophy. So you have to ascertain the size of the adenoids and flexible laryngoscopy. So the grading of the tonsils, as you can see, this is oropharyngoscopic view. We have grade 0 means that the tonsils are within the fossa, the tonsillar fossa. Then grade 1, they are at the level of the pillars. Grade 2, they are slightly be above, like 25% is above the pillars or beyond the pillars. Then we have grade 3. This is 50% beyond the pillars. So that is 75% of the tonsils. And then grade 4, we call them the kissing tonsils. They touch one another. So when you look into the oral cavity, you can always grade the patient, and that is a grading from grade 0, 1, 2, 3, and 4. So this is grade 4. You can see these are tonsils. They are clean, they are pink, so they are not infected because we see that mucosa is pink, and we see these deep crypts, you see, but we see that they are touching. So these are kissing grade 4 tonsils. The risk factors, usually the etiology, in 5 to 30% of these cases, they're bacterial, and 39% of these bacterial cases, we have beta-lactamase producing organisms, and sometimes anaerobes. The most likely organism we are dealing with is group A beta hemolytic streptococcus, and we do throat culture and we treat accordingly. Most common organisms cultured from these patients with chronic tonsillar hypertrophy, we have streptococcal pyogenes, or group A beta hemolytic strep, Haemophilus influenza, Staphylococcus aureus, or Streptococcus pneumoniae. Differential diagnosis, we have infectious mononucleosis, malignancy like lymphoma, leukemia, squamous cell carcinoma, diphtheria, which is now rare because of its vaccination, scarlet fever, and granulocytosis. Medical management for patients with acute adenotonsillitis or chronic, penicillins, the first line of treatment, whether you have culture or you don't have. So if we have acute upper air obstruction, usually you can put a nasopharyngeal airway, give the patient intravenous antibiotics, ceftriaxone, maybe with Expen, steroids, and if the response is poor, then you need to do immediate adenotonsillectomy. Recurrent tonsillitis, we end up giving a penicillin injection, IM benzathine, because we are concerned about non-compliancy. Chronic tonsillitis or obstruction, we can give antibiotics for a period of 3 and after 3 to 6 weeks, we can consider tonsillectomy, where we permanently remove the tonsils, or adenotonsillectomy. I remove both the tonsils and the adenoids. The most recommended penicillin that we use is amoxicillin, but it is we use the one which is augmented amoxiclav. So we give coamoxiclav, recommended dose per age, for a period of 10 days for tonsillitis. Treatment of adenoiditis, we give antibiotics. As we said, we have to cover the beta-lactamase streptococcus pyogenes using amoxiclav. Then we give the patient intranasal normal saline drops because these are mucolytic to try and break the mucus. And then after that, we couple it with intranasal steroids to try and reduce the size of the adenoids, topical. Then we add oral antihistamines like chlorpheniramine in children. If the symptoms do not resolve on this treatment for a period of 1 month, sometimes we go ahead and recommend adenoidectomy. So this is, as we have said, the first line is penicillin or cephalosporin for 10 days. And if the patient is resistant, sometimes we can give injectable, macrolides all azithromycin, all erythromycin, and clarithromycin, all. So if a patient is severely compromised with maybe dysphagia, we give them injectables. Complications of adenotonsillitis. We have both suppurative and non-suppurative complications. So the suppurative complications, we have cervical adenitis. That's when the infection has gone to the lymph nodes in the neck, which can later progress to the neck abscess, which we shall see later on in your tutorial, in your lectures. Peritonsillar abscess, quinsy, which we shall also see. Intratonsillar abscesses. So we can have a neck abscess, that is an abscess, a collection of pus within the neck, or we can have peritonsillar, that is pus around the tonsil, which is quinsy, or intratonsillar, that is pus inside the tonsil, that is the intratonsillar abscess, and jugular venous thrombosis, that is inflammation of the internal jugular vein because of its close proximity to the tonsils. The non-suppurative complications are usually from the group A beta hemolytic strep, and these include rheumatic heart disease, rheumatic fever, and post-streptococcal glomerulonephritis. That is all with acute adenotonsillitis. Just a quick recap, we saw that the adenotonsils are lymphoid tissue within the Walde's ring, and the adenoids are found within the nasopharynx. The tonsils are found in the oropharynx. When they get infected, the patient will be obstructed, evidenced by nasal obstruction, mouth breathing, and snoring. And they also have pain on swallowing if it's tonsils that's adenoidophagia. Most likely, we can have viral and bacterial. 39% we have bacterial, and out of those cases, most of them are caused by group A beta hemolytic strep. So when we have an acute episode, we treat, as we have seen, with antibiotics, penicillin-based antibiotics for a period of 10 days. And if all these fail, we can proceed to do adenotonsillectomy. Okay. So pharyngitis. Pharyngitis is an inflammatory disease of the mucosa and submucosal structures of the throat. It affects the oropharynx, the nasopharynx, the hypopharynx, the tonsils, and the adenoids. It can be acute or chronic, and if it occurs with tonsillitis, it's called pharyngeal tonsillitis. Acute pharyngitis may follow a viral infection, maybe from rhinovirus or respiratory syncytial virus, coronaviruses, any virus that causes an upper respiratory tract infection, usually associated with the pharynx. Because, as you remember, the pharynx is part of the upper respiratory tract. So we can have viral causes. We can have trauma, maybe from a foreign body. If someone has ingested maybe a fish bone and it is stuck in the oropharynx, or instrumentation, like having adenotonsillectomy can also predispose to pharyngitis. Or it can be a feature of other infections like measles, other systemic infections. Clinical features include a sore throat. So the patient will have painful swallowing, fever, and when you do oropharyngoscopy, you see hypertrophic, hyperemic pharyngeal wall, ovular, and adjacent facial tissues, that is the pillars, and thick secretions. If we have prominent tonsils, that is if it's pharyngeal tonsillitis, then you have enlarged cervical lymphadenopathy. So this is an image, oropharyngoscopic image, and we see, this is the uvula, anterior pillar, posterior pillar, and this is the posterior pharyngeal wall. We see the whole pharyngeal mucosa is hyperemic. You see it's hyperemic and a little bit congested because of the edema. And you see this thickening, these small like pimples. These are called cobblestones. So this patient has acute pharyngitis. As you notice that we have 0 tonsils. So this is an acute pharyngitis. Viruses, we have adenoviruses, we could have bacteria, group A beta hemolytic strep, it could also be fungus in patients who are immunocompromised, or those who have been abusing drugs or who have been on prolonged antibiotic therapy. And sometimes it could be irritants, especially in those patients who are allergic, maybe allergic to smoke, or they're working in a dust producing factory, like those who work in cement factories, or it could be trauma from ingestion of a foreign body. Diagnosis, we do history, clinical exam, and we can do also throat culture for group A beta hemolytic strep. Treatment for acute pharyngitis, usually we start with supportive and then we go to specific. Supportive include bed rest, hydration, humidification, lozenges. The lozenges we have seen, we have methyl plus. Hydration, each patient, like 3 liters of water per day. So that is hydration, but also that can include other fluids like orange juice or juice. Then we have saline gargles. Saline gargles, that's when you tell the patient to make 500 mils of warm water. They put a teaspoon of salt, they mix, and then they gargle and spit. So that is saline. It helps to clear the congestion and also reduce on the bacterial load. Note that the salt in the saline shouldn't be too much because it will cause dehydration, and it should not be too little because it will not do any job. So it's a teaspoon in 500 mils of water. Then antipyretic, in case it's viral in a child and they have a fever, you need to give maybe paracetamol to reduce the fever, or analgesia. So you can also give paracetamol for both analgesia and the fevers. Then an antihistamine, because of the congestion. Sometimes you can give a combination of an antihistamine with a steroid like Apidon. It has both an antihistamine and a steroid, dexamethasone. Then in case we have an upper respiratory tract infection, then you give a nasal-decongestant like oxymetazoline. It is a nasal decongestant that is short-lived and should be used for a period of only 5 days. Then we have antibiotics and anesthetic nasal sprays. So antibiotics, as we saw, most likely penicillin is your first number 1 recommended unless the patient is allergic to it. And then we have anesthetic sprays that make swallowing very easy, like xylocaine spray or BBC spray. That's what we have on the market. Other variant of pharyngitis, we have membranous pharyngitis. Membranous pharyngitis is rare these days because of vaccination. However, it is caused by Corynebacterium diphtheriae infection. And the membrane formation is formed on the facial tonsils. Features, we have grayish white membrane, which is extending from the soft palate uvula It cannot easily be removed and it bleeds when removed. Patients who have features of septicemia such as tachycardia, pyrexia, and paradoxical slow pulse with hyperpyrexia. So the fevers will be high and you expect the patient to have a tachycardia when they have high fevers, but in this case, it will be a vice versa. The patient will have a low pulse and yet they have a high grade fever. Complications of membranous pharyngitis, we have soft palate paralysis because diphtheria affects the nerves. So it will affect the cranial nerve 9, 10, causing you soft palate paralysis, phrenic nerve, giving you diaphragmatic paralysis, acute tubular damage of the kidneys, myocarditis, and upper air obstruction from the membranous tissue. So this is membranous. It's different from, you see it is thick. It involves the soft palate and it bleeds when you try to scrape it off. Diagnosis is from culture of the plex and a gram stain to show the bacilli. Coenobacterium is a bacilli. Treatment, it's an emergency. You have to secure the airway using a tracheostomy with high oxygen flow, high dose penicillins, and you need to administer the antitoxin in the first 48 hours. I have had one patient of this illness. It was a 3-year-old boy who came in with sudden onset of flu-like symptoms, and on examination they had the grayish white matter all the way from the nose and the nasopharynx extending all the way to the oropharynx. The tonsils were covered with that edematous grayish matter. However, we were unable to secure the antitoxin within 48 hours and the child died from acute myocarditis. So it is an emergency disease. Chronic pharyngitis, it is usually non-specific, and this occurs, patient has a sore throat for more than 3 months. Risk factors include for chronic pharyngitis include post-nasal drip, that is in chronic rhinosinusitis, because as you saw in your lectures, the mucus in the sinuses beats towards the nasopharynx, so they will have a post-nasal drip. Irritants such as dust, dry heat, chemicals, smoking, and alcohol. These are components that cause chronic pharyngitis. Reflux esophagitis, that is the acid coming from the stomach, refluxing into the oropharynx, can cause pharyngitis. Chronic mouth breathing in children with adenoid hypertrophy. Voice abuse, singers and pastors. Allergy to anything can also include allergies that can affect the oropharynx, like particular drinks with sugar, all coldness, and dust and scents. Granulomatous diseases and connective tissue disorders. These are systemic diseases that have a component of chronic pharyngitis and malignancies. Patient who come in with constant throat clearance, that is a feeling of constant throat clearance. They have a dry throat, odynophagia, that is painful swallowing, global sensation. They keep on feeling like they have a pill that is stuck in the throat. So the patient will say, I feel like I swallowed food and it is stuck in the throat. Cough spasms, patient who wake up and they cough, and they want to cough their lungs out. Thickened or granular pharyngeal wall and pharyngeal crusting. These are noted on clinical exam. So clinical history and examination, the key in the diagnosis, and culture and biopsy if failed empirical therapies to rule out malignancy. Treatment usually is to address the underlying etiology. avoidance of contributing factors like smoking, dust, dry environments. Symptomatic treatment is similar to that of acute rhinitis, the gargles, the lozenges, the antibiotic, the antihistamine, cough suppressants, vitamin B complex. They're also entailed in treatment. But from clinical practice, the number one cause of chronic pharyngitis in our setting is reflux. So once you test and notice that they have H. pylori and you treat the H. pylori and acid suppressants like PPIs or omeprazole, we end up having these patients cleared. They stop throat clearings or feeling like their throat is dry. So with chronic pharyngitis, it's very important to rule out the cause by talking through a clinical exam. The patient will tell you the risk factor. They'll tell you, doctor, I have a dry throat, but I also have a full stomach. Sometimes I feel chest pain and fire in my stomach. Then you know that maybe the risk factor for this chronic pharyngitis is reflux. Then you go ahead. Or the patient is a smoker, or they have allergies. They will tell you that this problem in the throat, I clear my throat more when it's cold or when I take sugar. So it's important to remember this list so that when you're dealing with someone with chronic pharyngitis, you try and rule out or rule in those risk factors because the treatment is entailed to the risk factor. Lastly is laryngitis. Laryngitis is inflammation of the larynx. We saw the larynx has 3 compartments. We have the supraglottis, the glottis, and the subglottis, the space below the true vocal cords. Acute laryngitis is characterized by inflammation, hyperemic mucosa congestion, as you can see in this image. Then we have membranous laryngitis, which is from Corynebacterium D3. You can see that this is, we have this membrane that is extending from the epiglottis, extending all the way to the true vocal cords, the false vocal cords, and the true vocal cords. This is a membrane closing. So this patient most likely definitely will have upper airway obstruction. Then we have, this is a patient who has what we call croup, which you will cover later in upper airway obstruction. You can see we have edema of the subglottis. Remember, croup is acute laryngeal tracheobronchitis. If you haven't covered in PED, we shall also cover it in upper airway obstruction. Then we have vocal cord lesions, which occur in chronic laryngitis. You can have boggy lymph through vocal cords, or you can have as you can see, this is a polyp from the edge of your vocal cords. So that is chronic. So acute inflammation of the larynx for a short period of time, usually less than a month, is called acute laryngitis. The predisposition include excessive use of voice, that is phonotrauma. Upper respiratory tract infection, like viruses, rhinovirus, or herpes zoster, or bacteria like Haemophilus influenza type B. Haemophilus influenza type B, we shall see it also again in acute epiglottitis. Or we can have fungal Candida albicans in the oral cavity, in the larynx also. So we can have smoking predisposing someone to laryngitis, sinusitis, tonsillitis, trauma. So sinusitis and tonsillitis, that the infection in the pharynx can easily spread to the tonsils and I mean to the larynx and cause laryngitis together with the tonsillitis. And sinusitis is because of the mucus that beats and it to the back of the nasopharynx, and with gravity goes directly into the larynx, excuse me. Pathology, as you see, we appreciate the 5 components of inflammation when someone has laryngitis. These include functional lazy, so there's loss of function because we shall have a hoarse voice. The patient will have dysphonia or hoarse voice, and we know the function of one of the functions, as we saw of the larynx, is voice production. So the patient will have function loss, so hyperemia, edema, pain, they'll have pudendophagia and rubra. So these are the components of inflammation which you know from pathology. And on examination, usually examination of the larynx is done using either an indirect laryngoscopy, that is a laryngeal mirror. You hold the tongue and you look down using a mirror, and then you're able to appreciate whether we have edema of the mucosa or intracaudal hemorrhage or thick fibrous exudates. You can do direct laryngoscopy, either using flexible laryngoscopy, that scope we saw that you use through the nose and you look down into the vocal cords. Or you can use rigid, which you use through the mouth, and then it's an angle and you're able to appreciate the vocal cords. Or we can have tenderness on palpating the larynx, as we saw from your Adam's apple, then that is laryngeal perichondritis. Clinical features of acute laryngitis include a hoarse voice, throat discomfort, painful swallowing, dry throat, dyspnea in case we have severe cases and we have upper air obstruction, fever, and malaise. On examination, which is either by direct laryngoscopy or indirect laryngoscopy using a laryngeal mirror, you see congested laryngeal mucosa, dull hyperemic edematous vocal cords, and thick secretions, as you can see. So this is the picture, a flexible picture, laryngoscope picture, and you can see that these vocal cords are normal. They're usually pink. The mucosa is pink, these are white, these are false vocal cords, your glottis is open, so this is normal. And then you see this in acute, the true vocal cords are edematous, and you can see some mucoid discharge and they're hyperemic. So this is acute laryngitis. Treatment includes raise the voice, supportive includes raise the voice, warm humidification, that is the steam inhalation, hydration, analgesia and antipyretic in case a patient has pain and fever. Antibiotics usually group penicillin-based antibiotic like amoxiclav, steroids in case you suspect air obstruction, and oxygen. So that is the management of acute tonsillitis, laryngitis. Then with chronic laryngitis, we have voice hoarseness of voice for more than 3 months, and the most common cause of voice change over that time is GERD, gastroesophageal reflux disease, the reflux of acid contents from the stomach into the airway. Other causes include recurrent acute bacterial laryngitis attributed to Staphylococcus aureus, mycobacterial laryngitis, that is TB, tuberculosis of the larynx, Fungal laryngitis, fungus in the larynx, especially in patients with inhaled steroids as inhalers and low immune status. Poor laryngeal hygiene, like heavy tobacco smoking, alcohol, irritant fumes, and heavy caffeine use. Chronic infection of the nasal sinuses because of the mucus that beats towards the nose. Mouth breathing from nasal obstruction, and voice abuse. These patients will come in with hoarseness or loss of voice sensation, constant clears the voice, tired voice, and spasmodic cough. So, hoarse voice, okay? Hoarse voice is I think you understand what a hoarse voice is like. The patient's voice loses its normal quality, and the patient will tell you, oh, my voice has changed. They will constantly clear the throat, that is okay, or they will have a tired voice or spasmodic cough. On examination, we shall have hyperemic irregular laryngomucosa. The true vocal cords may be edematous, or we can have granulomatous, ulcerative lesions, or thickened vocal cords. The differential diagnosis for chronic laryngitis, chronic hoarse voice, you need to rule out malignancy, cancer of the larynx, or cancer of the vocal cords, because of risk factors such as smoking. So you have to ascertain if the patient has a risk factor for getting cancer, especially nicotine exposure. Inhaled steroids, those can predispose to fungal. Laryngeal paralysis, maybe we have a tumor outside infecting the vagus nerve. We saw the vagus nerve is one that supplies the true vocal cords, or TB. So management includes voice stress. Voice stress doesn't mean someone to keep quiet, but it means the patient should not talk too much, should not talk too loud, and should not whisper. Every time a person whispers, you use more energy than when you speak normally. So you have to emphasize that with voice stress, no whispering at all. Just speak at the normal. Your voice might not be as clear as possible, but speak normally. And then avoid smoking. Lifestyle modifications. Lifestyle modifications include rest the voice, hydration, do steam inhalation, avoid acid eliciting diets like oily, fatty, spicy foods, citric acid-based foods, all carbonated drinks. Those kind of increase the acid. And then you give medications such as for those like for acute laryngitis. However, remember, when you suspect TB, you need to do direct laryngoscopy and take a biopsy. So you have to take this patient to theater, and you're able to visualize the vocal cords and the theater and take a biopsy from the lesion, from where the problem is coming from. And in case you also suspect malignancy, you have to take the patient to theater, take a biopsy to confirm what type of cancer they might have. The other component that you never forget in chronic laryngitis is anti-reflux inhibitors like proton pump inhibitors, PPI. You need to reduce acid, which is burning which might be burning refluxing and causing havoc on the vocal cords. Okay, so just a recap. Today we talked about pharyngitis, acute adenotonsillitis, and laryngitis. As you can see, it is inflammation. You find out the cause of the inflammation. You find out how the patient is presenting. So and then you manage accordingly. In children, we have seen adenotonsillitis. It can be inflammation or it can be obstruction. With obstruction, we have no infection, but we have very big adenoids and tonsils which are obstructing them, and we have to do we saw that if it's acute, usually it's from infectious causes, but when it's chronic, then you have a long list of risk factors and you have to rule out or rule in one of the risk factors and manage the patient appropriately. With laryngitis, we say that we have acute and chronic. Acute, most of the time, is inflammatory or infectious, but with chronic, then you have to rule in or rule out things like cancer of the vocal cords. Thank you so much. In case we have any questions, if we don't have, do we have any questions? Okay.
Miro, please, I can ask your question.
Okay. Thank you, Dr. Jamilah, for the presentation. So I have two questions. The first one is in children, are there indications for prophylactic tonsilloidectomy in which you can have your kid tonsils removed so that they don't get all these disorders of the tonsils? Then the second is what's the natural cause for pharyngitis? Like without treatment, how many cases actually go unnoticed? Because when I was on internal medicine and clinical rotation, realized many patients were coming with rheumatic heart disease, but they not have any memory of pharyngitis or strep B pharyngitis. So it seems like you can have it and then it heals on its own. That's majority of the cases, and then later you present with features of rheumatic heart disease. So what's the natural cause? And then the first one was what is the role of prophylactic tonsilloidectomy?
Okay. So we shall start with the first one. The first one is the role of adenotonsillectomy. So we have an international guidelines for adenotonsillectomy. We have international guidelines for adenotonsillectomy. One, we have obstructive symptoms. Two, we have if you suspect malignancy. Three, we have recurrent adenotonsillitis. That suits the criteria of 5 episodes per year, 7 episodes per year, 5 episodes per 2 years, 3 episodes per 3 consecutive years. As we saw, the Waldear's ring, where the adenoids come from and the tonsils, is part of the protective aerodigestive tract. So they protect a child from getting severe pneumonia and severe gastric infections that can cause more harm than them just getting sick. And as we saw previously, that the infections with the adenoids, when they do not get sick, they are physiologically meant to regress by the age of 5. They will regress, and by the age of 8 to 12, the patient should not have adenoids. Whereas for tonsils, they start regressing by the age of 8 years, and then by 16, or by the age of 16 years, they will not be able to, they will not be, they will have regressed or become atrophic to grade 0 or grade 1. So you do not need prophylactic adenotonsillectomy because physiologically, if the adenoids don't get sick or if they don't fit the criteria, they will regress by themselves. So the body will do itself to reduce them, and then they will disappear, or they remain a remnant. If they persist even up to the age of 30 years, we have done adenotonsillectomies in patients who are 30, 35, 48, 50. So if they do not regress, sometimes they can cause trouble to the patient for a very long time, and we have to end up doing the adenotonsillectomy anyway, regardless of the age. Okay. So the second question was about patients who have been discovered to have rheumatic heart disease and they have no history of pharyngitis. It is hard to know the natural cause of a streptococcus because it's an infection and we have streptococcal carriers. It doesn't mean you should go and take a swab and do culture sensitivity to rule out that whether you're a streptococcal carrier. But we have patients who are streptococcal carriers. They carry the bacteria in their oral cavity, and they can spread it either by aerosols to others. The others they spread it to, they get the symptoms of a sore throat, fever, and they're treated, whereas the streptococcal carriers are not treated. So how do you know you're a streptococcal carrier? It is only through doing culture and sensitivity. And how do you summon culture and sensitivity for yourself? I am sorry, believe you me, it is hard. So, but in their lifetime, they should have had an episode, one or more, of a sore throat. So as we have seen in this presentation, the number one cause of a sore throat bacteria-wise is group A beta hemolytic strep or streptococcus pyogenes. So when you see a patient who has a sore throat, please kindly, as you treat them, add penicillin-based antibiotics so that they do not get the non-suppurative complications of group A beta hemolytic strep. Okay, thank you. Any other question?
Yes. Please unmute and ask your question.
All right. So thank you so much, Dr. Jamilah. My question is in relation a little bit to what Mira asked. How often do we see people who have acute glomerulonephritis, a complication of streptococcal infections, which are causing laryngitis? How prevalent do we still have acute glomerulonephritis? People who have been treated and those have been treated are well for laryngitis secondary to probably to streptococcal infection. Thank you so much.
How common is the non-suppurative complications, which include rheumatic fever, rheumatic heart disease, and post-streptococcal glomerulonephritis? So the post-streptococcal glomerulonephritis has reduced because of the penicillin-based antibiotics that are now very readily available to all kids. However, the instances of rheumatic fever and rheumatic heart disease are going up. So it is very, we even have a study ongoing in the hospital where we are doing echo, assortitis. Remember, those are like the assortitis, that's a hematological test to know if the patient has group A beta hemolytic strep. So it's an anti-streptococcal streptolysin or titers. Okay, again, that's the streptolysin that's produced by the bacteria. So yes, the cases of rheumatic heart disease and rheumatic fever from group A beta hemolytic strep are high. So it's still present. Any other question?
Yes, we have a question from Miro. Bire, please unmute. And by on that note, doctor, there is a case Bire sent for us in group. I emailed you this morning on your email. It's
okay.
No ears. Maybe you take it out. But Bire, unmute and ask your question.
Thank you, Dr. Jamilah, for the lecture. I appreciate you so much. I have two questions. One is my time in the HIV clinic, I've come across children who are HIV positive and they have extensive oropharyngeal candidiasis, but they present similarly with tonsillitis and pharyngitis. In such cases, how should we manage them? facilities where we cannot do culture and sensitivity. Then the second question is, I've also followed up children vaginally born to mothers with genital warts, and 6 months or in their life they develop laryngeal papillomas. So they present like with difficulty in breathing, failure to breastfeed. How do we manage them with sleep apnea, obstructive sleep apneas almost throughout the night? How do we manage? Thank you.
Okay, thank you. So one, a patient being HIV positive does not stop them from getting all the other diseases. So when they're HIV positive, they can be predisposed to other diseases than normal people get. So for children who are immunocompromised, the most likely cause most of the time they can have a fungal pharyngitis or pharyngeal tonsillitis. And ideally, you should cover them for both bacterial and fungal. So you treat them with an antifungal, maybe fluconazole, 200 milligrams OD for a period of 10 days with an augmented penicillin, amoxiclav, together with fluconazole for a period of 10 days, dosage adjusted for age. In case these children do not resolve, it is advised that you refer them for adenotonsillectomy. So we have done a couple of adenotonsillectomies on children who are HIV positive. One, the other risk factor is that when they have HIV positive, their immunostatus is compromised. However, the lymph nodes enlarge in response to the viral load. So you find that sometimes they have these very big tonsils that are obstructing and they're not infected. So they also have to be removed for just the fact that they are HIV positive and the body is trying and couple down the infection. And in that process, it recruits lymphatic structures. And as we know that the tonsils and the adenoids are lymphatic tissues, so they end up growing. So I've done a couple of adenotonsillectomies in HIV positive children. And we say that the adenoids regress by the age of 8 completely. However, in HIV positive patients, I have removed adenoids, very huge, like an apple size adenoid in a 20-year-old who was HIV from birth. So HIV itself also elicits an immune response, which in that role of the body to fight against the virus, it ends up causing hyperplasia of the adenoids and the tonsils. So if they're obstructed and they are not breathing, they have to seek medical treatment. And if medical treatment fails, that is 10 days of fluconazole and an antibiotic, then you have to refer them for adenotonsillectomy. They also deserve to breathe better. The other thing you have to remember is the other components also play a role, like a steroid, a low-dose steroid. It's also useful regardless of someone's immunostatus. Oral salty gargles, that's also useful regardless of someone's immunostatus. So that is very crucial to remember. So your second question was about children who are born with mothers who have warts. As we shall see later on, we have respiratory papilloma or respiratory papillomatosis. That is when you have papillomatous lesions occurring on the vocal cords. And the number one symptom that this patient will come in with, or this child will be brought in with, it will be loss of voice or aphonia or hoarseness of voice. So a child who comes with a hoarse voice is regarded as respiratory papillomatosis until proven otherwise, because there are other causes that can be congenital, such as a laryngeal web or subglottic stenosis, or there are other acquired causes like maybe acute laryngitis, maybe from chronic rhinosinusitis or chronic mouth breathing from the adenoid hypertrophy. But the number one, or a foreign body that has gone and sat on the vocal cords, like there are patients from Kasese who have removed this silverfish that was ingested and it got stuck on the vocal cords. So they come in with hoarse voice. But in patients born with mothers who have genital warts, because of that vertical transmission of the warts, of the HPV, they end up having laryngeal papillomatosis. So the patient will come in loss of voice. And we said that the larynx is also airway, conduit of air. So they'll have loss of voice and airway obstruction, because the papillomatous lesions, they grow in the pathway of air. So there's no treatment other than surgery. So we have to take this patient for surgical debulking. We take them to theater and we remove as much papilloma as possible. And we also give them maybe we can do intralesional interferon, which is not affordable for for 90%, 99, including me, of our patients. So we do serial excisions. We can also do oral antivirus like acyclovir, ganciclovir, retinoic acid. So there are other medical treatments, but they are combined with surgical excision, called excision or using laser. But in our setting, we usually called knife. We remove them, we debulk the tumor from the vocal cords. The other thing you can do in your setting where you are exposed to the large community is to advocate for vaccination to these mothers. And also children who are born to these mothers now, we can vaccinate them with ganciclovir, which is against HPV, as early as 1.5 years of age. Because the earliest a child can come in with respiratory papillomatosis is 8 months, but that is rare. It's rare. The commonest age of presentation is between 2 years and 6 years. So if you predict that this child might end up having trouble with respiratory papillomatosis, then you recommend for vaccination, the Gardasil, or I think we have Gardasil on the market. So, and it's available in Zambia Hospital or other hospitals in Kampala. So you can always refer your mothers with their children for vaccination so we can prevent that. Thank you so much. Any other question?
We have a last question from Mase Kobusinje.
Okay. Yes,
Mase, please
Matthew.
unmute.
Thank you, doctor. Mike, when you were teaching about EBV virus or EBV, you said you need to ascertain so well that it's EBV because you should not give penicillin. I understand that penicillin has no place to play in a viral infection, but is there a particular contraindication that would happen if you gave it, or you just said it because it will not be effective?
So when you give it, the patient will get an overwhelmed response because the antibodies against the EBV in the blood also mimic. They can read the penicillin as the EBV antigen. So because of the similarity in the structure, the body overwhelms with anaphylactic dermatitis. So they get overwhelming rash and itchy throat, and the symptoms worsen. So it's because the body reads the penicillin, the antibodies meant to fight for EBV are read in the body. They read the penicillin in the body as the EBV, also as EBV. So that's the role why you have to stay away from penicillin, because the situation will worsen other than improving. Okay. So anytime you give a patient a penicillin and they call you the next time and say, oh, my daughter has gotten a rash, you just have to stop the penicillin there and then. Okay, any other question?
There are no more questions, Doctor.
Okay, so just a recap, because streptococcal carriers exist, so your assignment for today is to write short notes on Group A beta hemolytic strep pharyngotonsillitis, management, complications, and prevention. Thank you. Because you are not going to have mid-sem, and your end of semester will only have constitute 5 questions, each assignment given will carry 10 marks. So I have started marking. 5 of you have not handed in the second and the fourth. But just to resound myself, kindly inform your colleagues that these assignments are going to, half of them will contribute to your mid-sem and half of them will contribute to your end of sem. Thank you. I will leave the meeting. Okay, so write short notes on Group A beta hemolytic strep pharyngotonsillitis, its management, complications, and prevention. Thank you. Write short notes on Group A beta hemolytic streptococcus pharyngotonsillitis, management, complications, and prevention. Prevention of someone becoming a streptococcal carrier.
Excuse me, doctor.
Yes, please.
Good morning.
Good morning.
Yeah, this is Janet Maraka. I would like to know when the deadline for the assignment.
The deadline of assignment, I have pushed it to Friday at 5 p.m. But kindly note that anybody who is submitting above that, I'm also rejecting. Okay, so that's why you see some of you, even when you submit, I say you see 5 people did not submit because you submitted before, after the deadline. So there's only 2 people who called me and excuse themselves, but the others, if the deadline is met and you have not submitted, I am sorry. Okay, thank you. Have a lovely day.
Lovely day too.